everybody. It's 7 o'clock. We get rolling with grand rounds. We'll be doing grand rounds with in just a moment, followed by the This is an associate professor here in our department. She's also the director of our simulation education program. Dr. Best trained here at UW. She was here for medical school, followed by 1-year fellowship research year at the University of Minnesota in endourology. Came back here for residency, and then left us for 2 years to UT Southwestern under the tutelage of Drs. Pearl and Kadedu in endourology and kidney stone disease. And with that introduction, she'll be presenting to us on the medical management of nephrolithiasis. Dr. Best.
Thank you, everybody. Cool. So you share your slides. I don't know how to do that. Send projector. Here, I thought it was smart. Okay. Guess I did know how to do that, but not quickly or nearly as efficiently as you think, indeed. Awesome. All right, now I think we're in business. Well, it's my pleasure to get to talk to everybody this morning about a topic that probably everybody's realized I'm pretty passionate about. And I think, in the next few minutes, it's not letting me, oh, there we go. I hope to show you that this is really a practical, easy thing for everybody to do in their practice. Even though it has kind of a bad rap that medical management of stone disease is hard and there's all these labs and there's a lot of treatments and it's hard to know which one to do. I really feel strongly it's not that hard to learn how to manage the vast majority of patients. It's really just a few drugs. If you learn how to use potassium citrate and thiazide, you're going to be able to manage the majority of patients with drugs. There's a few dietary recommendations. Most of them are pretty logical and are going to go with the patient's other health concerns. And most importantly, it's really annoying, it's effective. So if you manage your patients with surgery, that has a lot of downsides to it, right? The stents are miserable. It causes people to be off of work. It's like a ticking time bomb. People don't know when they're going to be inconvenienced and in agony, things like that. So the wins in stone disease really are in the prevention, and it's effective. So people who take potassium citrate, calcium stone formers who were prescribed this had an 80% remission rate with long-term therapy. And those who were started on a thiazide went from making almost 3 stones per year to nearly 0. So that's a big win and something we should all learn to be able to do. In the next few minutes, I'm going to talk about the epidemiology and pathogenesis of stones briefly, then spend most of the time talking about the different types of stones and the guidelines-based management of diagnosis and management, and then a few words on the follow-up. So epidemiology, the NHANES data set, which is a large prospective data set collected that is really excellent for studying diseases in a large population, found that there has been a linear increase in the prevalence of stone disease. And while historically we taught that men were much more likely than women to have stones, that gap is really narrowing, probably due to increasing rates of obesity. Stone disease, again, peaks between the 4th and 6th decades of life, but this too is becoming younger, again, probably related to obesity. White Americans have a greater incidence, and weight and BMI correlate with stone risk more in women than men. The pathogenesis of stone disease is actually a chemistry thing, and it's things that you learned about back in your junior high or high school chemistry class, and it's driven by the supersaturation of urine. So it's the same deal if you remember that you would have like a beaker of water and you had to keep dumping sugar and salt in and stirring it and put as much in until it would no longer dissolve in there, and then it would precipitate out at the bottom. That's supersaturation. So that happens for the various crystals that go on to form stones. So it starts with crystal nucleation, so crystals forming. And then when they get heavy enough, they do a process called aggregation. And if they're really heavy enough, then they are weighty enough to kind of hang out and they are retained rather than flushing out in the urine. And this can lead to stone formation. I've got some pictures here of things that I think all of you have seen that are called Randall's plaques. And these are thought to be papillary damage resulting in calcium apatite deposition in the basement membrane in the nephron. And this is thought to provide an anchored surface for stone deposition once it erupts through the urothelium. So this is something that can appear on exam questions. And when they look, do micro CTs of stones that have been plucked off of where they're still attached, they will see at the attachment point, it might be a calcium oxalate stone, but at the site where it was attached, they'll find apatite at that base. Stone inhibitors, thankfully, are present in the urine that increase the level of supersaturation needed for crystal growth, meaning you can cram more crystals into the solution before they precipitate out. TAM horsefall protein, which is the most abundant protein in the urine, is one of these, along with nephrocalcin, uropontin, and various glycosaminoglycans. So for the majority of the rest of my talk, I'm going to review essentially the pertinent points from the AUA medical management guidelines. So I'd encourage everybody to look at this document. I think this is a very approachable, readable guideline. It has a lot of great information that's easy to digest and is a great reference as well. So the medical management guidelines divide the assessment of patients into essentially two categories. So your first job is to determine, is the patient a low-risk stone former or a high-risk stone former? And a low-risk stone former is anybody who is a first-time stone former who has no red flags that put them at higher risk for stone disease, which we'll talk about a little bit more, but basically this list. On the other hand, a high-risk stone former is somebody who's had stones before, who has more than one stone at the time of initial presentation. Any pediatric patient considered high risk. Solitary kidney because of the risk of renal failure. It's a high-stakes situation if they were to drop a stone in their ureter. And then anybody who has those medical conditions in that list. So patients who are low risk undergo what is called the screening evaluation, while those who have a high risk are considered to undergo the metabolic evaluation. So what is that? The screening evaluation, just like anything when we're taking care of our patients, involves getting a good medical history from your patient and some labs. So the pertinent issues for a screening evaluation, again, you want to find out, does this person have a family history of stone disease? You want to get a good dietary history as part of the guidelines, and then a medical history. So the medical history pertinent conditions here, a lot of these we're going to cover while we are talking about the various stone types and their risks, but there's a lot of things that we can pretty easily ask about in about 30 seconds to ask patients if they have these conditions. Asking somebody if they have diarrhea or loose stools or how many bowel movements per day are they having, because a lot of patients only know their own normal GI function. So asking them that can provide a lot of information. But these other conditions as well, if patients have them or know that they have them, can put them at higher risk. Additionally, you want to look through their medications and supplements. Many of them are listed here. So calcium and vitamin D overconsumption can be linked to no benefit to the patient and potentially a higher risk of stone formation in some patients. Same deal for high doses of vitamin C. The carbonic anhydrase inhibitors, which cause a renal tubular acidosis type condition. A few medications that cause hyperuricasuria. Trimethoprim, furosemide, and some protease inhibitors can be pertinent as well. So you go through those things, and then you're also going to obtain serum labs, including a basic metabolic profile, a serum calcium and uric acid, and then it varies. You can consider getting a PTH right off the bat, or wait and see if you have hypercalciuria or hypercalcemia. And then, of course, getting a urinalysis, which is going to give you information about the acidity or alkalinity of the urine, and as well as looking for positive urine culture. So again, here's your low-risk stone former. It's the first time, nothing jumps out at you on the history. You do a screening evaluation. and you don't see anything that jumps out, then you can make the general recommendations to them without doing a 24-hour urine. So you're going to recommend they drink a lot of fluids, they watch their salt and animal protein intake, don't do crazy consumption of oxalate, and consume the recommended daily allowance of calcium. So on the other hand, if somebody has a red flag, if you will, on the history and labs, then you want to get the metabolic evaluation, which is what it's called in the guidelines, but really it's just that screening evaluation plus a 24-hour urine. And we're going to spend a lot of our time this morning talking about what to do with that. So first and foremost, we'll talk about calcium stones and its risk factors. So calcium stones are far and away the most common type of kidney stones that you're going to see. So if anybody, you guys probably all know that I'm fond of asking you what you think the stone is made of when we're doing a ureteroscopy, and you can nearly always guess calcium because that's going to be the vast majority of patients. But hypercalciuria is one of the risk factors for, one of the more common risk factors for calcium stone formation. And while it's not necessarily, as we'll talk about, super critical to figure out exactly which of these your patient has if they have hypercalciuria. I think it is important for understanding and potentially for some testing purposes. But there are three ways that people can be hypercalciuric. The most common is absorptive, which is GI hypercalciuria, which means that the gut is overly efficient at absorbing calcium from the foods that we eat. Pretty straightforward, actually. I don't know why it has to have an unfortunately similar name. But the other second most common cause is renal leak. So normally the nephron, filters your blood, and so it filters all of the different parts of the blood, and it's supposed to reabsorb the vast, over 90% of the calcium that is filtered in the nephron. And it's supposed to put it back in the bloodstream. But people with renal leak have an actual defect in their nephron, and they can't reabsorb that calcium efficiently. So just like it sounds, they're leaking calcium into their urine, and that's how they have hypercalciuria. And then finally, hyperparathyroidism is another potential cause, the least common, but is an important one to identify, reasons we're going to discuss. But all three of these can lead to hypercalciuria. But importantly, only two of them can lead to hyperparathyroidism. For all of us to know, that's important for us to try to find out, because hyperparathyroidism has an effect of reabsorbing your bones, right? So that can cause osteoporosis and put patients down the road at risk for pathologic fractures. So you can really make a huge difference if you identify these patients. The people with primary hyperparathyroidism, of course, that's the problem. They have a gland that's overproducing PTH hormone. But people with renal leak, it's a secondary issue. So this is a busy chart here, but it more is of a reference. But the secondary hyperparathyroidism comes because your body is wasting calcium. So because it's a really important thing to maintain, our body has a bunch of different hormones that work strongly to maintain a normal blood calcium level, right? So it will sacrifice your bones in order to maintain normal calcemia. And so PTH is one of the big hormones that's used to do that. So your PTH level is high, but it's a secondary cause. So you don't need to find out who has the overactive GI tract. You need to find out who are the people with hyperparathyroidism, primary or secondary. So you can figure out if they have primary or secondary hyperparathyroidism by checking that PTH and a serum calcium. And this is in the guideline. You only need to find the primary hyperparathyroidism patients, because obviously that's an entirely different treatment. They would have surgery for that gland, whereas the other two patients are adequately treated with thiazides. And you can really save somebody's bone health by prescribing that. So we can't talk about hypercalciuria without talking about the importance of sodium. So those of you who have been in clinic with me doing 24-hour urines, we always, when we see, somebody has high urine calcium, we want to jump our eyes over immediately to look at what the sodium is, because sodium drags calcium out with it in the urine. And oral sodium intake is completely related to how much you eat. So if you eat it, you're going to pee it. Our body only needs a little bit of sodium per day, and the American diet in particular has way more than we need. And so all that extra sodium, you're going to pee it out, but it's unfortunately going to drag calcium with it. And there's actually a mathematical relationship between the two of these that can be valuable for trying to figure it out. So for every extra 100 milliequivalents per day of sodium that you eat and therefore pee, it will increase your urine calcium by 50. So what does that mean in a more practical sense? So let's say you've got somebody who has mild hypercalciuria, 230 milligrams being excreted per day, and you jump your eyes over and they have high urinary sodium of 300. If you tell this person, let's get you to drop your dietary sodium, and they get it down by 100, so still pretty high, right at that borderline, they're going to expect to see a 50-point drop in their urine calcium, which in this case is actually going to normalize it for them. So, so this is important to address. But the other reason you have to address it is even if sodium isn't completely to blame for this person's hypercalciuria, the medications, the thiazides, their effect is attenuated. They don't work if you have too much sodium in your diet. So you have to do both. So even if you have a urine calcium of 430 and there's no way that you could consume drop your sodium enough to have it make a difference, but their sodium is high, you still got to do both. So put them on a low sodium diet and give them a thiazide. Any questions so far? So thiazides, as I mentioned, are the mainstay of treatment for hypercalciuria, and it works for both the GI hypercalciuria and the renal leak. And so it's really effective. As long as you've ruled out that somebody doesn't have primary hypoparathyroidism, you can try using this medication. And it works by augmenting the calcium reabsorption in the distal tubule, which corrects the actual defect in renal leak. So it's a perfect drug for that. It fixes the problem, if you will. But in the GI one, it doesn't really affect the GI absorption. It just compensates, and your gut that's overly efficient at absorbing calcium from the foods you eat and putting that into your bloodstream, it does a good job, the thiazide in this case, of putting that excess calcium into your bones to maintain a normal blood calcium level. Here's a list of the potential drugs and doses. The ones that we use, I think, really depends. They all work well. The chlorthalidone and indapamide have the advantage of being once-a-day medications, which is easier for compliance. But really, they all work great, and you just get to know using one or the other and become comfortable with it. I will mention amiloride plus hydrochlorothiazide, which is a combination pill. Amiloride is a potassium-sparing diuretic. So if patients don't need a citrate supplement, this can be a great option to maintain a normal serum potassium. Which leads me to my next statement, which is that all drugs have side effects, and for thiazides, they can be significant. The one we think of most commonly is hypokalemia, and so we always got to check our patient's serum potassium anytime we change that thiazide dose, about 7 to 10 days after we start. And the treatments for this are sometimes we put patients on a potassium supplement or the amiloride combination pill. And some people can keep up with enough of their dietary consumption, but important to know about. Additionally, we're going to talk a little bit more. This is a potential cause of iatrogenic hypocitraturia. So if you are following a patient for a few years and their hypercalciuria is under control with the drug, but suddenly they've got hypocitraturia, could be related to the drug. It can also cause a gout flare in some patients as well and cause hyperuricasuria potentially and hyperglycemia, which is pertinent, especially since so many of our stone patients are diabetic. So let's shift gears and talk a little bit about hyperoxaluria, which is not very common. So this, I think, is a big send home message from this portion of this topic, is that hyperoxaluria really only affects about 8% of patients with stones, compared to 60% potentially of patients with hypercalciuria. There are 3 different ways, just like in calcium, 3 different ways that you can have hyperoxaluria. The first is primary hyperoxaluria. The second is dietary, which can come from either eating too much oxalate or more commonly a low calcium diet, which we'll talk about, or enteric hyperoxaluria, which is associated with conditions of fast GI transit. We'll talk about that as well. So for years, my talk on this topic was very stagnant, and the main statement about primary hyperoxaluria was thankfully that it's rare. It's due to a liver enzyme deficiency, and it has an early age and onset. And so for years, I would say the only, this was universally to cause renal failure, and the only treatment was a combined liver kidney transplant. But in one of the greatest innovations in endourology in recent years, there's now a new medication on the market. And it's important to know about this. We'll talk about the med in a second, but I think there have been a lot more studies also on pH in the last few years as well. And so while 50% of patients with pH will end up with renal failure by age 15, 21% of them may not present until adulthood, and they may have like the occasional stone. So I had long thought it didn't really, if I wasn't a pediatric urologist, I didn't need to necessarily think about this, but there are definitely patients who have pH who you may not diagnose until they're a full-blown adults. So it's important to think about this. And there's genetic testing available to assess for this. But lumasiran is the new medication that is a new drug that's an RNA interference agent. This could conceivably show up on tests, I think. And it targets the glycolate oxidase, meaning that it blocks, it prevents the substrate for oxalate synthesis from forming. So it interferes earlier in that whole cycle there. And a double-blind placebo-controlled trial showed that there was a 65% reduction in urine oxalate levels in pH patients on this drug, and that 84% of patients ended up with a urine oxalate of 1.5 times normal or less, which is a dramatic improvement, right? So if you identify these people, you can not only hopefully reduce their stone formation, but also prevent that deposition within the nephron itself, that the nephrocalcinosis and tubular damage that can lead to renal failure. So this is a big deal. Oxalate, as mentioned, comes from two ways. So even if you did not eat any oxalate whatsoever in your diet, your body makes it. So endogenous production typically results in about half of the average urinary oxalate excretion per day. But dietary is important as well. We used to historically tell people it didn't really matter how much oxalate they ate because it's poorly absorbed. Only about 10% of what you eat is absorbed through your gut. But if you eat a ton of it, even 10% can be a significant amount. So it's important to ask people about this. But my big selling point here is that every stone former and every urologist, if you ask them what do you do for the dietary prevention of kidney stones, they'll be like, oh, they got to stop eating spinach, the hyperoxaluria. And so let's be honest, like how many of our patients here at UW do you think are eating their way to kidney stones because of too much spinach? It's almost no one, right? So it's a very easy thing. Patients remember that, even though, again, most of them not eating a ton of high oxalate foods like spinach smoothies or things like that. And again, it's only 8% of stone formers who have hyperoxaluria in the first place. So if you tell somebody to stop eating spinach, number one, that's a really healthy food, which we're going to talk about. But secondly, that probably wasn't the problem for the vast majority of your stone patients. But they're going to think, oh yeah, I'm doing a great job. I'm doing what the doctor said. I'm not eating the spinach that I was never eating in the first place. So I think that recommendation takes up a lot of bandwidth for our patients and for our time and isn't very helpful. But the other reason is lots of people are not eating a ton of oxalate, and instead they may have a diet that is low in calcium, which we obviously need for bone health, but also what it does is it binds up the oxalate in the gut, and the calcium oxalate complex in the gut can't be absorbed, whereas free calcium and free oxalate can be absorbed. So in many cases, it's important to get a good dietary history, and that's why we are incredibly lucky to have Dr. Peniston here, who's amazing at doing this and super smart about all of it, of course. But she really has been teaching, I think, all of us about how important it is to maybe not focus so much on telling people to stop oxalate. And the reason is that if you have a low oxalate diet, that's often a nutrient poor diet or a less healthy diet because there's a lot of fiber in those foods. It's often associated with a higher urine pH, which a lot of our patients need, and other things that are important. And she and others actually did a wonderful study that's shown here in the slides here and found that patients with hyperoxaluria, you had equivalent effect if you told people to just restrict the oxalate in their diet versus added calcium plus the dietary changes. They both had a nice improvement in their hypoxaluria. Again, here's a list of the foods. There's a lot of misinformation out there, but again, foods that are high in oxalate often have a lot of fiber and magnesium, and alkali, all of which typically help prevent stones. So if you limit them, then you might run into trouble. So I think it's worth checking to see, is your patient somebody who is doing 3 spinach smoothies a day? Then that's somebody to worry about. Additionally, I have seen somebody eating a whole can of peanuts every day, and they had hyperoxaluria and a crazy high urine sodium. And anecdotally, talking to other people, nuts is another one that I have heard other people have. So if somebody's not eating a ton, the person eating a spinach salad a couple times a week this is not their issue. So more commonly, it would be helpful to add calcium-rich foods to a patient's diet. So lastly, enteric hyperoxaluria, like I said, is a condition of fast GI transit. So anything that causes diarrhea or frequent stools can cause this. And the reason for that is when you have chronic diarrhea, you have fat malabsorption, which leads to excess fatty acids in the gut compared to normal. And fatty acids, if you remember your chemistry, are negatively charged. They're anions. And so they like to bind up the cations, calcium and magnesium, and they do that avidly in the gut lumen, which means that poor oxalate is also negatively charged and it is left there without a dancing partner. So because, as I mentioned before, free oxalate can be absorbed from the gut lumen while calcium oxalate cannot, that free oxalate then gets absorbed. This process is called saponification. So chronic diarrhea, also just a big time not good for stones. It causes reduced urine output because you might have dehydration or be losing your fluid from your stool. If you remember, you're learning the causes for metabolic acidosis when you were in medical school. The chronic diarrhea is one of the causes. And so overall, best to get that under control. Another thing that we see a fair bit these days is patients who undergo bariatric surgery, and this can be a risk for significant hyperoxaluria. And actually, interesting to hear this nice story from Drs. Asplin and Co. looked at patients who were non-stomers, idiopathic stone formers, and then those who'd had the 2 forms at the time of bariatric surgery, and they found both of these had dramatically high urine oxalate levels. In particular, jejunal ileal bypass, which was the bariatric surgery technique of the 70s of choice, actually caused people to go like a pH syndrome where they would go into renal failure, actually. So it actually caused that surgery to be banned. But even those with standard Roux-en-Y gastric bypass can have significant hyperoxaluria. So important to be asking about that as well. Any questions on hyperoxaluria? Okay, Hypocitraturia. So another really common cause of stone formation, affecting about 39%. And citrate, compared to the other things that we're talking about, is actually protective. So it is another negatively charged molecule, or it's an anion that likes to bind up those naughty cations, calcium, and it's protective. So it chelates calcium, but it also inhibits crystal nucleation independently. And so who ends up with low citrates? So people who have metabolic acidosis for whatever cause. So citrate is related to bicarb. It's sort of on this pathway. They are interchangeable for a lot of your thought processes. So people who have metabolic acidosis, if you think about it, they have, our bodies will do darn near anything to maintain a normal serum pH, right? That's incredibly critical. If somebody doesn't have a normal serum pH, like they're really sick, that's bad. So normal serum pH, your body does whatever it can. And so one of the mechanisms is to hold on to all of the buffer that it can and not excrete that in the urine. So bicarb, citrate, that pathway is one of these buffers, and your body will hold on to it, meaning you have less showing up in your urine. This can also happen in renal tubular acidosis, which we'll talk about. RTA, or distal RTA, which is the one associated with stones, type 1, is the inability of the body to acidify the urine. It is a primary defect. So normally, again, the metabolism in the human body is an acid generating process. And so one of the ways that our body gets rid of that excess acid from metabolism is to dump it in the urine as protons or acid. And that's why people normally have acidic urine. And so people who have distal RTA don't have that ability. They can't, no matter what acid load they eat or metabolize or whatever, they can't compensate by dumping extra acid in their urine. And so they end up with that acid building up within their serum, if you will, to make it simplified, and they end up with a metabolic acidosis. So this causes a hypocalemic, hyperchloremic metabolic acidosis. And I like to lump things together when I'm trying to memorize things. So does anybody know of anything else that causes in urology a hypocalemic, hyperchloremic metabolic acidosis? Dr. Richards knows. What is it? Ouch. So I know everybody has to know. So it's the urinary diversion. So doing like a ileal conduit or major bowel resection can cause that as well.
Yeah, that's why we try to keep the limb to 15 centimeters. I measured several times because if it's too long, then you're at much higher risk for that complication.
Who gave this man a microphone? Now I feel like I'm gonna call on him. That's wonderful. So we talked about metabolic acidosis, so iatrogenic. So I already mentioned earlier thiazides. This can be a side effect, and then idiopathic. So how do we approach hypocitraturia? Well, as with most things, we're going to start with dietary approaches. So vegetarians are stone formers who are vegetarians. Almost never are they hypocitraturic. Unless they have RTA or something else or a medication cause. So vegetables, fruits and vegetables can increase the citrate in your urine. Also, lemon and orange juice can potentially do this. The issue is that you have to drink a lot of those to be a significant citrate supplement. And those, because they're so sour, are usually flavored with a lot of sugar, which is not good for us or for stone formers. But say you can't get enough movement with the diet alone, then we have a few different options. So traditionally, potassium citrate was the drug that we used. We start it typically 10 to 20 milliequivalents 2 to 3 times a day. It's the slow release tablets. So this is another thing. I have, in this last 6 months, had a couple of patients tell me they stopped it because they thought they were paying all this money for this expensive pill and it wasn't working because they could see it in the toilet when they pooped. And you have to remember to tell people that the medication is essentially leached out of the wax matrix. And so it's working even though they see that wax matrix in the stool. And then if somebody has a condition of fast GI transit, they may not have enough time for that leaching out process to occur. So you might want to give them a liquid formulation. And finally, I'm going to spend a couple minutes talking about sodium citrate or baking soda or sodium bicarbonate. Again, citrate and bicarb are kind of on that same pathway there. And this can be a super cheap option and cause less GI upset sometimes. So things to know, potassium citrate and baking soda both also increase urine pH, which is good in a lot of our patients. We have acidic urine is a risk factor independently. So a lot of our patients, we actually want their pH to go from 5 or 5.5 up to 6+. And so you get a bonus with treating that. But there is a potential risk of switching patients over from making calcium oxalate stones to calcium phosphate stones, because calcium phosphate stones form in an alkaline urine environment. So it is a little counterintuitive. Patients who have renal tubular acidosis, so they're going to have a high urine pH, right? Because they can't dump that extra acid in there to make the urine more acidic. So they're going to have a high urine pH, but their bodies are holding on to all the bicarb and buffer that they possibly can. So they're going to also have a very low urine citrate. And the treatment for people with RTA is to give them potassium citrate, or often a lot of potassium citrate or buffer, sometimes a combination of approaches, because they have an acidosis, and your job to correct the condition and to protect their bones and their overall health is to correct their serum acidosis. So it seems kind of counterintuitive. You got somebody here with this who's making calcium phosphate stones because they have RTA and they already have a high urine pH, and you're going to give them more potassium citrate, which may increase that. And actually, there's the classic study on this that specifically looked at it, was by Dr. Preminger, and it was only 9 patients, but they put 9 RTA patients on potassium citrate and followed them, and they found that their overall rate of stone formation dropped significantly, even though their urine pH went up a bit. So it's still important for the patient's overall health to address their acidosis and therefore hypocitraturia. So I promised I would talk a little bit more about the baking soda. It's a big thing here at UW because folks here have done a lot of the work on trying to really study that deeply. So alternative alkali is one of the other phrases used for this. So that would include baking soda, potassium bicarbonate, and actually a variety of other things that are available over the counter on the market that are supplements that try to add these things as well. And the folks at Duke actually did a nice study looking at patients with hypocitraturia and giving them either potassium citrate or an alternative alkali agent such as baking soda. And what they found was that both treatment groups experienced a significant increase in their urinary citrate levels, and especially if you look at the people in the alternative alkali group actually started with a much lower baseline. And so they both had a dramatic increase comparatively in their citrate level, as well as a significant rise in their urine pH. But most importantly, neither group experienced an increase in their urine calcium. So why haven't we just been throwing baking soda at people all the time if it's effective? And it's because we're traditionally afraid that sodium leads to calcium being excreted or dragged out in the urine, right? So we are traditionally, as urologists, we've been afraid of doing that and causing somebody hypercalciuria. But what we're finding is that it's more complex than just the sodium. So some people are even thinking that maybe it's the chloride of sodium chloride that is the one that's causing the hypercalciuric effect of a sodium load. Or a salt load, shall we say. So it did not cause hypercalciuria by putting patients on baking soda. All right, any questions about that? Okay, hyperuricluria. So again, relatively common, and it is by definition an elevated urinary uric acid. So this means uric acid stones, right? So uric acid stones. No, so it's the tricky thing here is that this is a common source of confusion. Uric acid stones are not caused by hyperuricluria. It's actually caused by low urine pH, acidic urine. So people who are diabetic or have metabolic syndrome, those folks who can often have a profoundly acidic urine, they get uric acid stones. It's not typically the people with hyperuricluria. In fact, so we treat low urine pH with potassium citrate. We care about urinary uric acid because it increases calcium oxalate stone formation. So uric acid can act like a grain of sand inside an oyster around which a pearl forms that's calcium oxalate. So we want less of that crystallized uric acid around so that there's less calcium oxalate stone formation. So how do we treat elevated urinary uric acid? Again, we start with diet. So proteins, particularly animal proteins, have a ton of nucleic acids in them, and nucleic acids can be part of contain uric acid once metabolized. So important to reduce the dietary animal protein. I was involved in a study when I was a fellow looking at the different types of meat, red meat, white meat, and fish, because I think lots of people think that they just need to cut down on their red meat for kidney stones, but actually gram for gram, the effect of fish was the greatest. I was pretty sick. I had a metabolic acidosis from the acid load of that. Plus it was disgusting eating metabolic kitchen fish every day for a week. But anyways, it's important that they restrict all kinds of animal protein. If diet is insufficient, then we want to alkalinize the urine. So alkaline urine makes uric acid much more soluble, so it's dissolvable, meaning it's not there as a grain of sand to allow a calcium oxalate stone to form. And then allopurinol. So this, again, is one of the more misunderstood aspects of metabolic stone management. Allopurinol is almost always used for calcium stone formers with hyperuricasuria who keep making stones despite addressing other aspects of things. So it's like a third line treatment typically for calcium stone formers. But it's a great choice if somebody also has gout, for example, or things like that. But a misused drug. So again, a few words on uric acid stones. Most patients with uric acid stones have a normal uric acid level. So kind of mind blowing, but it's a problem of urine acidity, not an issue of their uric acid. And so this is actually Dr. Pearl's favorite chart, and it looks really complicated. But what it's showing you that you've got the pH on one line here, and you have the amount of undissolved uric acid in this line here. And what it's essentially showing you is that if you increase the pH, you can dissolve dramatic amounts of uric acid in the urine with little tiny moves in increasing urine pH. So rather than trying to cut down the amount that's in there, the total amount, you might as well just put your bang for your buck in making the urine far more able to accept more uric acid by making it a little bit more alkaline. All right, a couple words on, we have two more types of stones, infection stones. So infection stones, also frequently known most of the time, are struvite stones. The classic is the staghorn stone at presentation. Classically for this, for a infection stone to form, the urine pH will typically be 7.5 or higher, so over 7. And that's because that's actually why the stone forms. So urea splitting bacteria listed here create this high urine pH environment that causes crystallization of struvite within the urine to form these types of stones. So we've got the nice list of bacteria here. You know, what's not on there is E. coli. So if somebody, the vast majority of isolates of E. coli are not urea splitting. So you may have somebody who has a colonized stone that's calcium oxalate or something else, but it will not typically be causing, if it's the only bacteria involved, E. coli usually isn't it. So how do we treat infection stones? They're a little bit different than the other metabolic stones. It's critical to completely eliminate them through surgery because essentially I liken it to a coral reef where the bacteria make it and then also live within it. And so you got to destroy the whole coral reef in order to get all the bacteria out of there. But perhaps even more importantly than that, once you do that, you have to monitor for and prevent recurrent infections. So there's a lot of debate in endourology about giving these people longer courses of antibiotics. I typically do give them about 3 months of antibiotics because if there's a few bacteria hanging out, then they start the whole process over. The fastest I have seen somebody who had a perk at an outside institution come back and see me with a new full stag was within 6 weeks. The stone reformed in 6 weeks. So it can happen crazy fast. And so you gotta, even if you don't give them antibiotics prophylaxis, you have to keep checking to make sure that they're not getting recurrent infection, which can be especially tricky in our patients with indwelling tubes, right? So these are the ones that are nearly impossible to manage because you can't keep their urinary tract stable. Or sterile. More for learning purposes, lithostat or acetohydroxamic acid is a drug that is a urease inhibitor, and it will reduce urine pH. So we have lots of times that we deliberately increase urine pH, right? Our uric acid stone formers, we give them alkali and it increases their urine pH. Much trickier to drop somebody's urine pH. So this drug can do that. But the reason why none of you have seen this being used is because it is pretty darn dangerous, and really only used if surgery is not an option. But the people in whom surgery is not an option are also not really able to tolerate a very high side effect medication, including like a 15% rate of DVT. So all those things play together to not really be a commonly used drug in the US. A couple words on cystine stones. So this is an autosomal recessive disease affecting the transport of the dibasic amino acid. So the abbreviation is COLA. Thankfully, only cystine is insoluble at normal human urine pHs. And so these people often present with a large stone volume, potentially at a young age. And it crystallizes when you have more than 250 milligrams per liter in the typical urine. So what's the goal if patients have cystine stones? So at this point in life, unfortunately, we can't change people's genetics. So our goal is to reduce the concentration of cystine below that solubility limit. So you can do that by a couple different things, right? You can decrease how much cystine you're eating. So protein restriction, hard in kids and generally not recommended in children with cystinuria. Or you can increase their fluids. So these are people who need to drink like 3.5 liters a day. And so that will decrease the concentration. So you can decrease the solute or increase the fluid to get there. And also sodium appears to affect the crystallization of cystine as well. And then unfortunately the pKa, while the pKa of uric acid is thankfully really low, so it's easy to dump lots more in the urine with a slight increase in pH, the pKa of cystine is 8.3, which is not really physiologically achievable, but the target is a pH of 7.5, which can often be a crap ton of potassium citrate, an alkali for these patients to take. And then finally, alpha mercaptopropional glycine, which I had to learn to say as somebody who lectures on this topic, because you're not supposed to use the trade names that everybody uses for this drug in most CME presentations, but it is also known as Thiola. And this medication promotes a disulfide exchange. So what cystine does in the urine is bind together in a dimer, and what Thiola does is it cleaves that bond and it binds to one of the cysteines, like the cysteine, the other spelling, the amino acid version. So that is more soluble and gets peed out then. So the side effects though of this drug are unfortunate in that they cause GI issues, some rash, hematologic effects. You got to do a lot of blood test monitoring and potentially proteinuria, which is important in these patients with bad stone disease. So that's the last few words on cystine. The guidelines, just a word or two here. I know we're over time. So the guidelines recommend that we should repeat a 24-hour urine within 6 months of initiating any form of therapy, which makes sense, right? If you were going to start a blood pressure medication, you would want to check your blood pressure and make sure that it was better on the drug that you're taking so that you make sure it's worthwhile what you're doing, or you don't need more, or a dose adjustment or something like that. And then it recommends checking it again annually. You might need to check labs to assess for the adverse effects of our pharmacotherapy. You should repeat the stone analysis when it's available. So if somebody has another stone, just because they had a calcium oxalate stone in the past, if you have a stone material to send, it's worthwhile because they could be converting to calcium phosphate theoretically. And then the guidelines give a nebulous statement about periodically obtaining repeat imaging to assess for recurrence. So in summary, this was a ton of material, I know that, but it's not in practice all that complicated. You really got to find the important medical conditions. So you want to find the people who have hypercalcemia, so checking that BMP that's going to have the calcium. So you identify the patients with primary hyperparathyroidism. You also want to find the folks with distal RTA because they are going to be sick and have issues with bad bone health and just be crummy with stones. So finding those, that's actually not that hard. Hypercalcemia, that's a lab test. If you see somebody with a urine pH of 7.5, and they're not on Topamax, that's somebody you should be thinking about for RTA. And, finding those can make a big difference in those patients overall, not just stone health. Just a couple of different medications. We use potassium citrate for practically everything. So you're almost never wrong to give potassium citrate. It can help with hypercalciuria, which I didn't really talk about, but it is great it's the treatment for hypocitraturia and low urine pH along with alternative alkalis. Guys, I pick one, get to know it, be familiar, make sure to recheck that potassium. This can be a big deal for patients. And I will point out that say you're just terrified of doing a 24-hour urine or your patient just won't do it. You've ordered it 15 times and they just don't do it. Or you're in a health system where you can't get it. It is perfectly guideline supported and research supported to prescribe either of these drugs for patients just with calcium stones, which you can tell because you're going to be right over 80% of the time just across the board. But if you can see it on the x-ray and it's not a struvite stone, it's probably a calcium stone. And there's good data to support strong benefit of either of these medications empirically. So you can use the drugs without the 24-hour urine. And then finally, the bonuses are identifying any ridiculous consumption, like a can of peanuts every day, and then allopurinol we use for bad hyperuricasuria and calcium stone formers. This is just for reference because sometimes these crystal shapes show up on tests. And then again, this, I know this is hanging in the VA workroom, but is the summary that I made of all of the medications that we use for stone disease and their side effects and stuff. So this is available to anybody if you'd like it. And that's my puppy. Any questions anybody has? Anybody?
I have a question, Sarah. The guy with the microphone again. Thanks again for putting this together. Really, really strong talk. One of the, I think, innovative things that has come out of UW department is these shared visits for patients as part of their metabolic workup. Can you talk a little bit about how that program evolved? And then two specific areas has it been implemented elsewhere in other systems, some of the challenges maybe with that? And then how do you bill for those types of visits when you have a group of patients all coming in together?
Yes, so those are wonderful questions, and I know the answers to some of them, and Steve can probably comment alternatively. I am actually, because my clinic is not on the Tuesday Stone Clinic Day, I have not been personally involved in the group visits, but I know that the billing thing has been sorted out. I don't know the exact answers about that, but it has patients sign a consent, is my understanding, to get their care in this way. And then they get a bunch of essentially educational information that can be delivered so that patients can have more face time with providers to learn about their disease and have more time to understand all of this stuff. And then there's independent review of patient specific risk factors, of which they have consented to being discussed in the group, is my understanding. So I know Nikki Streeper is doing this in Hershey. So this definitely people who especially who've trained here, but this is definitely being done in other places. I don't know all the list of places, but I think it is a really novel approach, a way to be able to spend more time with our patients on something that seems complex. And I think a lot of patients really enjoy the camaraderie. It's, stone disease in a lot of patients can be a little bit like having gone to war. A lot of our patients have had a lot of misery and their quality of life affected. And so hanging out, just like our vets like to sometimes hang out at the VA or at the VFW or the Legion and commiserate with people who've had similar experiences, I think there's benefit to that. I don't know, Steve, if you have anything to add.
Sure, terrific talk. So a question about overlapping of specialties in the medical world. Where do you see the blend and overlap with medical management of stone disease with urologists and nephrologists?
So I'm about to get to learn that even more. I think I'm excited about that with my new opportunity. I'll be starting working at Litholink. Will involve talking to even more nephrologists. But I think what's interesting is that a surprising number of nephrologists don't actually know a ton about stone disease, more than, we do. For example, yes, they got it during their training, but many of them are more focused on dialysis and other things like that. So there are a relatively few number of nephrologists who are passionate about this. Like there are relatively few urologists who are passionate about it. So it may be that your center will have somebody, like we have Dr. Jaguru, who is really into it. But I think trying to find that person, if you're going to try to do a group clinic, I think they are particularly good at, I would certainly want to get them involved if the drugs become complicated or patients have ongoing CKD or risk for that in affiliation with their stone disease. So if somebody has CKD and you're needing to adjust their potassium because they really need a lot of citrate, or they're acidotic, or our cystine stone formers are at a substantially higher rate of going on to dialysis and things like that. I think having somebody who's super knowledgeable about the nephron and things like that can be really important to have on board. But I think it's not as common as I might have thought at one time that nephrologists are super nerds about stones. Yeah, Dave.
Yeah, thanks, Sarah. Great talk. So I know it's not sexy, but the light is.
You've not seen the commercials. You mean it has? So the question is, Crystal Light has about using Crystal Light for stone formers. So Crystal Light has a lot of citrate. Some of the formulations of Crystal Light can have a lot of citrate in it. Yeah, so I definitely do recommend Crystal Light to patients. It does not have, so like the lemon version of Crystal Light has more. I didn't include any of the slides that have the citrate content of beverages. But Crystal Light Lemon is certainly on that list. There are a bunch of other commercially now available beverage powders that are specifically targeting stone formers, like Lithiolite and Moonstone and various things like that, that have been designed to have a much higher load of citrate. Reason I do offer or tell patients about that is it's no calorie, right? So most of my stone formers are struggling with issues related to being overweight as well. And so if they go and drink a ton of lemonade with all the sugar in it and things like that, they are going to have worse problems with their diabetes, et cetera. But there's a million different flavors of Crystal Light, and it's a good way to add flavored water to your diet. The other, so it may have some citrate in it, definitely has fluid, obviously, but it does not budge your urine pH. So if acidic urine pH is the issue, then you're going to need to do something in addition, which some of those commercially available things also can adjust people's urine pH, whereas Crystal Light does not. Cool. Well, I have a bunch of cases for us to go through in rec, so.
Great. Thank you, Dr. Best. Yeah, thank you again for your time for residence in rec. And we are a little bit over, so let's switch on over to Indications Conference with the red and the blue services. Thanks.